Director of Surgical Affairs in RCSI. And on another glorious sunny evening, which seems to be the norm right now, we might just actually get used to this if we're not careful. I just want to welcome everybody to the weekly webinar. Tonight's webinar is going to focus on the future of perioperative care and what it may look like given the impact of COVID-19, I think, on all services. And as we try and recover services, I think this is really important for everybody to understand all the various aspects of that. Today we're joined, as always, by our President, Mr. Ken Mealy. While the President will give us the usual weekly update on matters, it is also to note that it's Mr. Mealy's last webinar as President of RCSI, as his term ends next week. And we'll be coming back to that at the end of the webinar for a chat with the President on that. Then we're also joined on an update from our National Co-Lead on the National Clinical Programmes, Professor Deborah McNamara, who will talk to us about the NCPS programmes perspective on perioperative care. Professor Paul Ridgeway, who's an Associate Professor of Surgery in TCD and Tala Hospital, and is also a clinical advisor to the National Clinical Programmes, and will give us a perspective as a clinical director on the issues of recovery of services. We're then also very much welcome Brenda O'Brien, who's the Assistant Director of Nursing for Practice of Development in the South Infirmary, Victoria University Hospital in Cork. And thanks to Brenda for giving her time tonight to come and talk to us from that perspective. And finally, Professor Tom O'Connor, who's a Deputy Head at RCSI School of Nursing and has many years experience and great perspective on what the whole issue of perioperative care and its impact on the nursing profession. And because it's as always, it's a big team effort. All of this work will have to be, and it'll be great to get those perspectives. So that's a good lineup tonight. As always, I'll just ask all our presenters to be mindful of the time. A lot of speakers that we can keep to our 8 to 10 minutes. That'd be fantastic. Lots of room for questions and discussion afterwards. That'd be great. As always, we use the chat function for people to raise questions and queries throughout the webinar. If you can ensure that you keep your voice on mute and your cameras on mute, that would be great. So without any further delay, we'll kick off as usual by asking the President to give us an update on what's been happening since last week with all the interactions at the department level and with the HSC. Ken, over to you.
Kieran, thank you very much, and you're all very welcome yet again to this. I think it's our 9th webinar, and I think we all understand that since surgery closed down because of the COVID pandemic, or scheduled surgery closed down because of the COVID pandemic approximately 3 months ago, there's been a huge disruption to surgical services around the country. And we're now in a position where we're trying to reorganize and renegotiate how we get scheduled care back into hospitals safely. Over the last week or two, we have moved from the damage limitation of surgical services and how we manage acute surgery in the COVID pandemic to how we reintroduce scheduled care safely. And it's a real pleasure to have our administrative and nurse manager colleagues with us and hospital managers who have given us some insight as to how we develop those care pathways, which are going to be so important. You'll hear tonight from our clinical leads who are working with our nurses and work with the anaesthetic program as to how we really define those pathways so that we can get patients into hospital. And that this is going to be so important so that we can do this over the next 4 to 6 weeks. And I think we're working, I'd like to tell you that we're working quite closely with the Acute Hospitals Division in the HSC to try and implement a safe return to surgery for those patients. We also have a central leadership role, and these topics are being discussed in the Department of Health and the HSC. And again, they're preoccupying everybody with some questions that are still unanswered. Hopefully, we will find out by the end of the week, for instance, whether the contract with the private hospitals will continue. And clearly, this will have important implications because it's quite clear from those that I talk to, there will be a real emphasis on maintaining a maximum of 80% bed capacity in the acute sector so that we don't have patients crowding in on top of each other, either in the wards or in the EDs. So we're really going to have to reinvent how we bring patients in for scheduled care with social distancing, with virtual clinics? How do we deal with consent processes? How do we pre-admit them? And then how do we have a COVID-free pathway? So these are all really important issues. I pay credit to our clinical leads, our specialty advisors in our own programs, but also in the other programs, particularly the anesthetic programs. And tonight we'll be really interested to hear what our nurse managers and administrators from hospitals around the country have to say. So I'll leave it at that for the moment, and I look forward to us getting on with the programme. Back to you, Kieran.
Thanks very much, Ken. That's great, and we'll be talking to you later on. We'll kick off now with getting an update from the National Clinical Programmes perspective on the future of perioperative care in the current climate. So as always, our national co-lead, Professor Deborah McNamara, finger on the pulse, knows where all the information is and giving all the answers here. So Debbie, as always, looking forward to hearing your updates on this. Thank you.
Thank you, Kieran. I have a few slides there, so I might get those up, please, Erica. Thank you. So just to introduce this section, I just would like to briefly cover 3 areas this evening. I suppose firstly, to show what we're trying to do in order to learn from our experience over the last 12 weeks, to highlight the location of some HSE clinical guidance that will be useful for surgeons in practice. And then finally, to make some recommendations about how surgeons can monitor the progress as we restore services. Next slide, please. So you've seen this before. This is the surgical patient pathway. And throughout the last 12 weeks, we've really struggled to maintain any sort of surgical services. I think it's fair to say that unscheduled surgical services have been maintained, but most scheduled work has not taken place aside from the most critical conditions. Next slide, please. So as we try to learn from what has happened over that period of time, when you look at the information, it appears that about 4 different types of pathways were operating for patients who presented for scheduled services. Some patients would have a questionnaire prior to being admitted to hospital. Some had a questionnaire and had a PCR test for COVID performed preoperatively. Some patients had a much more extensive workup with a questionnaire, a PCR test, and a preoperative CT scan, and some patients had no preoperative workup at all. And because the numbers were so small and because the country was in lockdown, the outcomes from that period of time will be very interesting to us. Next slide, please. So we have very limited information about the surgery that happened during the period recently, but thanks to collaboration with Dr. Vita Hamilton and Lorna Collins, the Senior Statistician in the Healthcare Pricing Office, we do have access to a small amount of data. In relation to patients, and this data ends on the 18th of May, so that's published on the day the lockdown exited and we began phase 1 of restoration. We would estimate that around 206 patients had an operation performed in an Irish public hospital during the period of the lockdown, which is really a very small number relative to normal activity. And we don't have very subtle data in terms of outcomes, but it would appear that of those patients, those 206 patients who had an operation and had COVID, that the mortality rate for that cohort of patients ranges between 9 to 12%, probably around 10% for patients. So I think this is somewhat reassuring in the light of international experience, which, as many of you will know, indicates a 20% mortality for patients who acquire COVID in the postoperative period. This is statistical data acquired from an administrative database, not from a clinical database, but it would indicate that the mortality for Irish patients operated on in teaching hospitals in our public system who acquired COVID had a mortality of approximately 10%. So I think that's the actual data that we have at present, and we're working to improve that data as time passes. Next slide, please. So we are currently working with a number of hospitals, and we're very interested in hearing from other hospitals who have provided surgical services during the lockdown period. What we're trying to acquire is a continuous series of the patients who had operations performed under general anesthetic, We're interested in both scheduled and unscheduled services, and we're particularly interested in the preoperative pathway of care in relation to how those patients were cared for preoperatively, what sort of testing was done to ensure that they were COVID-free, and we're trying to correlate that with the outcomes experienced by patients in the postoperative period. So the number of patients who became COVID positive, either on PCR or on the basis of a clinical diagnosis, and postoperative deaths or admissions to ITU. So we're working with a number of the hospitals, and what is different about this is that we've had very good collaboration from some of the private hospitals that have been involved in surgical services during this period. So we're hoping to acquire a series of patients just to see what the Irish data is, and using that information to help us guide how best to develop a perioperative pathway of care. And next slide, please. As most of you will know by now, there's a very up-to-date resource on the RCSI website that includes guidance from a number of sources. And on that website, and it will be put up as a link this evening, there is up-to-date HSE interim guidance on the RCSI website relating to the perioperative care of patients. And in particular, this is where the advice regarding cocooning, regarding preoperative testing with PCR for COVID, and with regard to care on a dedicated ring-fenced surgical ward, which is a COVID-free pathway, is contained. And I've highlighted there that this is very much considered interim guidance. It's been produced by the Acute Hospitals Division of the HSE. It has been shared with the chief clinical directors in all of the hospital groups. And it's a very, very cautious pathway. And because we don't know how the virus and the epidemic will behave in the coming weeks, I suppose we have to be extremely cautious. But what's important is that we learn from our experience as we reintroduce practice. Next slide, please. So there are a number of different projections for how the coming months and perhaps 2 years will play out. And over that period of time, it's simply not tenable that surgical services would be shut down over and over again in the coming months and years. So it is very important that we begin to collect data based on Irish populations, based on our own pathways, protocols, and our own citizens that demonstrate what the outcomes are for Irish patients following Irish protocols. And using that data, we will be able to support better guidance. So there is an important role for local surgeons and their own audit to demonstrate the safety of the perioperative care that we're delivering to patients who attend for scheduled surgery. Trying to improve the confidence of patients and of society in surgical services is a really important part of getting back to some activity. So what we are hoping to do is continue to collect data so that we can judge whether the interim guidance that we have issued is useful, whether it's safe for patients, and whether alternatives to that could be considered based on evidence. So in local hospitals, it seems like a good mechanism to evaluate how your own local pathways are working would be through the morbidity and mortality meetings. And so we would suggest that weekly surgical activity numbers would be considered, and the number of patients who become COVID positive in the perioperative period, those who have a clinical or PCR diagnosis, and in particular postoperative deaths or admissions to ITU that are unanticipated, should be recorded. Using local information is probably the most effective way of judging whether the pathways that we're introducing in local hospitals are safe. There will be lots of variation necessary in individual hospitals. And of course, in starting services, it's necessary for us to have a very conservative pathway, but it may be possible that we will have to adjust that over time. And it's important that we're all contributing to the learning from this. So if anyone is interested in contributing data to either the retrospective work that we're doing or moving forward into the prospective work, I suppose what is most important is that you have a clearly defined preoperative pathway for patients so that we can compare that to the outcomes experienced by those patients. Next slide, please. Just to bring to your attention again that the up-to-date guidance documents are available on the RCSI website, where there are local RCSI and NCPS documents, but also the guidance that has been issued by the HSE and NCCP. And that's a very useful location for surgeons to acquire these documents. And to remind you that our GP Surgeon Connect line is still operational, and to thank very much all of the surgical volunteers who are supporting that. Next slide. And once again, just to acknowledge all of the extended team who are putting in an awful lot of work at this time to try and get services up and running again. I've kept it short this evening, but I'm very happy to take any questions later on in the discussion. Thank you very much.
Debbie, thanks very much for that update. I mean, it might be brief, but it's showing the clarity that you're starting to bring to everything. And again, all the work that all you and the other clinical advisors are bringing to working with the HSE on the clinical programs. And just to remind everybody, all this information will be available to you on the RCSI website after the webinar tonight. And indeed, my colleague Pari Kelly has been putting up on the chat function links to the various documents that are being referenced as we go through the webinar here. So those may be of use to you to look into, but I think we're getting some very valuable resources there. Good information around clinical audit that will be important to start gathering in each of the hospitals. So our next speaker tonight then is Professor Paul Ridgeway, and Paul, who also is one of the clinical advisors on the clinical program and is Professor of Surgery at Tala University Hospital. And Paul is the clinical director in Tala University Hospital. And I guess, Paul, you know, your perspective as a clinical director now during all that's what's going on right now, you must have an awful lot on your plate, I'd imagine, but it'd be very, very useful for all of us to hear your perspective on what we need to do to recover services and all the whole perioperative area. So over to you.
Thanks, Kieran. Can you hear me okay? So thanks, Kieran. So my brief was to be brief, so that's what I'll do. Eric, if you wouldn't mind bringing up the slides. Great, thank you. What I was charged with doing is really bringing you a sort of a view from the ground. My first is the disclosure side, and apart from spending way too much time on Twitter in my off time, and also being the proud possessor of quite a bad haircut, as perhaps a lot of us are, I do have some disclosures around VHI, where I do a little bit of consultancy work with, and I'm linked in with some European groups for accreditation and training, as well as the aforementioned clinical programs. Next slide, please. Society has done quite a good job in flattening the curve, but I'll dial it back by 2 months just to remind us of the context which this all started in. We were all very worried that we would become another Italy type curve and that our services would be overrun. So a lot of planning happened both locally and nationally in order to mitigate that from as early as late February. Next slide, please. We know geographically from the data produced that the Eastern Seaboard certainly was hit, and Tala was hit as bad as anybody else. We frequently range in the top 4 of the hospitals that had both ICU and indeed ward-based COVIDs to quite a high level, and that still is ongoing, albeit at the back end of what is the first curve. That has allowed us to gain some good learning over the 2 months, but I suppose, next slide please, we had to get in early, and we were benefited by quite a strong executive management team who, with us clinicians, were able to plan effectively for very significant changes in how we do business. We had work streams which were looked after every week with regards to business continuity and the other things that other hospitals across the land had. Next slide, please. But very much in the last 2 months, we've been in that crisis mode, that direct leadership and innovation mode, and there's a general risk of fatigue around guidelines and so on and so forth. But guidelines, unfortunately, are what's going to get us out of this, more of which I'll discuss later. Next slide, please. So really, to set the scene and the context, and I know we've talked about this before, we have to consider what this happened in. And it happened in where surgical delivery in Ireland has been challenged over the last number of years. Bed capacity issues, the number of patients presenting to a number of different sites and so on represent significant challenges. And next slide, please. we were, where COVID came, it was in a situation where emergency care was delivered in safe but inefficient ways. And we've discussed this at various program meetings over the last number of years, specifically with regards to Tala, and it's not just a hospital level issue, it was a regional and national level issue. We had okay theatre access from an emergency perspective. Our acute surgical assessment unit was only working intermittently, largely because of boarded patients. And we had significant challenges around bed, both on the ward and in our intensive care unit settings. So those were the pre-existing challenges that we faced. Conversely, elective work was actually reasonably progressing in that we had plans for an off-site 4-theatre ambulatory care centre that's going to open later on this year. Our CN3 program for intermediate grade operating was working well, and we did have ring fencing initiatives around many of the specialties to allow them a reasonable elective throughput for their patients. Outpatients, as in other hospital sites, was significantly over capacity and remained a challenge. Next slide, Erica. So with that, the national figures, as Jerry has given us over the last number of years, showed that we, in terms of what we do as surgeons, about 78% in numbers terms what we do is the emergency work, what comes in through the ED. So that's our major work that we do day in and day out. Next slide, please. And we could be a bit better in terms of our length of stay. If you look at this graph, it is busy. It shows the top 200 consultant teams providing acute and elective care in the country, all in public hospitals. And the red lines reflect the private, public emergency caseload. And the red diamonds that you see scattered like confetti across the graph show their average length of stay. So there was no real correlation with volume or indeed length of stay on many sites throughout the country. Next slide, please. The system itself has some inefficiencies. We know tonight that we have 26 emergency departments fully staffed, open 24/7, providing full surgical and anaesthetic care. 24 have acute general surgery operating ability for that 24-hour period. Each of those sites have specific challenges, either being it in the rotas that they have, mainly super elective, which means that we do our acute surgery based on and around our normal work, and indeed bed challenges that surprisingly weren't a big issue on the ward when COVID struck. Next slide, please. Because when COVID struck, what we found was there was a huge drop-off in non-COVID activity. And that actually opened up our wards, that with the suppression of elective activity, and allowed us to become much more efficient in how we delivered acute surgery. Next slide, please. And again. We found that our surgical teams suddenly had a little bit more time because they were released from their elective endoscopy lists and their elective theatre lists, and they were able to attend to our patients at the front line. So what we found was that our PET times dropped quite significantly on site, mainly because we were able to deliver our senior decision makers very quickly to our patients. Next slide. And we almost had a reverse in that the elective and outpatients were suppressed, and suddenly our emergency system was working a little bit more efficiently than it was in the past. Our ward access issues were covered by the drop in non-COVID work that we saw acutely, and our ICU was expanded radically into our post-operative care unit area and also into our theatres, as happened on many sites throughout the country. And very early in the surge, we spilled into those extra areas. It was not an ideal situation, but it certainly was a situation that was made worse by the excellent ICU nursing and excellent intensivist support that we got throughout. Next slide, please. And the key themes that we faced on the ground are key themes everywhere across the country. How do we get about a return towards normal activity? What do we do to supplement that? And as Debbie said, the NCPS has published very good guidance on how, for example, virtual consultations can take place through outpatients to remove some footfall through local outpatient services. But concentrating on phased reintroduction to elective activity. Next slide, please. Really, we need guidelines, and that's been provided nationally for us. But as we know, these are evolving as we learn more. And we have to get used to the fact that we will probably be doing less with higher costs. These patients that come in, even to our outpatient services, are going to require some form of pre-assessment. Certainly those that go through the theatre streams are going to require enhanced resourcing around pre-assessment and swabbing where appropriate. And then post-operatively, as Debbie mentioned, we're going to have to cohort these patients in a different way, particularly in hospitals where COVID is still being admitted through the front door. Where should it be done? Well, from Tala, we operated a dual strategy in that we outsourced from early on, owing to the new Section 38 private hospitals. And we also insourced. The time critical or urgent elective cases were facilitated, but in a very controlled manner. Next slide, please. And again. And this controlled manner was done in a protocol fashion. And our protocols are similar to other hospitals around the country. We categorized our patients by procedures. Category A patients, low risk, no general anesthetic, for example, endoscopy, interventional radiology, minor ops, etc. They required a pre-procedural questionnaire, usually over the phone. They weren't swabbed unless they were high risk, and they received temperatures on arrival. Category B patients were your general anesthetic day cases, i.e. that there was an aerosol generating procedure as part of their care. Category C was the inpatient version of that. And then category D patients we had to specifically identify because we are quite challenged with regard to critical care spaces in Tala still. Next. And Angela Clayton-Lee, who's our business intelligence, who does all the hard work in our directorate, she came up with these phases and timelines based on what we think we could do relative to our COVID load at any one time. And the indicative dates on the right side have been adhered to so far, but we anticipate should there be a secondary surge, we can turn this off overnight. Next slide, please. So we do face a little bit of a tipping point now. We do have a situation whereby, next slide, we do have a situation whereby we do have a pull of the elective tensions coming back into the system. We do need to, as our president said, need to know the COVID status of the hospital, and Professor Sean Tierney and I and some others have done some work looking at consenting and the consenting process in the time of COVID, and that advice is available in the NCCP curated area. And we hope to have some updated advice coming out very soon that Jesse Elliott, who's a senior SPR that's working with us at the moment, has done a great job on. We don't and can't afford, though, to have our surgical and anesthetic staff on site. One of the big issues around the private hospital Section 38s is that a lot of the same staff are staffing both areas. And while the desire is to have COVID light streams and keep the COVID hospitals perhaps elective light, we still need to retain those staff to provide for acute rotas from acute surgical and acute anesthetic rotas in potentially COVID open situations. And indeed, as we're all hearing, funding and resource constraints aren't too far away. Next slide, please. So from my perspective, just to finish up, from a clinical director perspective on any of the sites that are dealing with COVID on an ongoing basis, we need to retain the efficiency in acute care, things like acute surgical assessment units give us. We need to also retain that ICU surge capacities. Before this, in peacetime, our ICUs were operating at well over 90%, usually over 100%. And therefore, we need to keep that surge capacity. And we also critically need to keep the increased ward capacity that we're seeing. We also, in the same breath, need to protect the elective stream, and that might be by reconfiguring or redesignating work in various hospitals that are now providing 24-hour acute care. Can you do the next slide, please, Erica? What has impressed me, though, throughout this in the clinical director role is that the ability and the flexibility of all concerned over the last 2 months to make decisions that were perhaps taking many, many weeks and months in peacetime overnight. I can't say all the decisions were good, similar to my choice of trousers in this picture, but what I would say is that They have been made, and they have been made early. And what we will need is that ongoing flexibility in decision making around the frameworks and guidelines that we receive in order to open up our elective streams going forward. Thanks very much.
Paul, thank you very much. And again, just to remind you that the slide with the yellow trousers will be available to everybody afterwards if they need to. But all joking aside, Paul, that's a really, really good summary of what's going on in Tallaght Hospital and your role as clinical director. Tough going, and I think there's a lot of questions there that people may be seeing from the information you've been given. So really interesting talk. Now we're going to move on to Brenda O'Brien, and Brenda is the Assistant Director of Nursing and Practice Development in the South Infirmary Victoria Hospital, University Hospital in Cork. And Brenda's going to give us a perspective on the perioperative network and the work she's been doing there. So Brenda, over to you, and thanks again.
Thank you. So Eric, if you could just put up the presentation. Okay, so just a little bit about the South Infirmary Victoria University Hospital. This is a photograph, and I'm sure you can see from it that the hospital is very old in some places and contemporary in others. And that in itself brings challenges in relation to IT, I suppose, pre-COVID-19, but particularly now with social distancing, you know, we are challenged in relation to an old infrastructure. Next slide, please, Erica. We are primarily an elective surgical hospital. We do not have an A&E department. We have a particular focus on day surgery, short length of stay, day of procedure admission, and we're the regional ENT and dermatology centre. You can see listed the specialties that are delivered in the hospital. During the pandemic, we were not allocated as a receiving COVID-19 hospital. However, we did transfer time critical services from the CUH to the South Infirmary Victoria Hospital, such as soft tissue injuries and fracture clinics. So again, the impact of the A&E, I suppose, admissions in relation to COVID-19, we didn't see that in our hospital, but did continue on the service to minimise interruptions within the group. Next slide, please, Erica. So just briefly, our activity in 2019, just to give you an indication as to the hospital and its productivity. So we have total beds of 192. Our total inpatient discharges in 2019 were 4,909. Our average length of stay is 4.74. Total day cases, 34,175. And of that, we had 1,514 paediatric patients, and our total OPD attendances were 70,866. So the productivity and the efficiency in the hospital and the rapid turnover makes for a very busy working environment. Next slide, please, Erica. So I'm here talking about networks and perioperative networks and the perspective, I suppose, on these networks, and they can be defined as a cooperative structure where interconnected groups or systems share a common interest or purpose or goal. The members attend as peers, so there isn't a hierarchical system. People respect each other, share their knowledge, and the information is based on trust and reciprocity. Next slide, please, Erica. So the potential advantages then to a preoperative networking group, and I'm aware that there is no such group nationally. However, we do have a preoperative senior nurse perioperative working group in the South-Southwest. But just to look at the potential advantages, currently what is happening nationally in organisations is, you know, excellent work, efficient work, effective work, areas where patients experience very positive experiences and report this back to us. However, this is not shared across the country or even across groups. And with a networking group, a national networking group, we would have access to personnel outside our own organisation. And by having that access to personnel outside your own organisation, you have creativity and innovation, and you have exposure to these local initiatives that are efficient and that are effective within this networking group that you in turn can bring back to your hospital site. There's exchange of information and knowledge between members. And again, you know, there are many issues in each hospital nationally where the organisation are trying to problem solve these challenges. Whereas again, if there was a networking group, they could be looked at a higher level and fed back and brought back to the hospital site, which again would create a minimal or eliminating errors in systems and practices. It also would give us the opportunity to standardise our approaches, and I suppose not really to reinvent the wheel. We would be eliminating repetition. Next slide, please, Erica. So the potential challenges then to a pre-op networking group, I suppose one of the biggest challenges would be sustained commitment of team members, and then members who would prioritise individual agenda over collective agenda. So that would be something that would be managed by good leadership skills by the group itself, and then agreeing on standardisation and prioritisation. And standardisation and prioritisation would need to focus on the service demands at the time and the service delivery and the policy and guideline around that particular time and what is needed. Next slide, please, Erica. So I'm just going to share an experience of a network group that I was involved with myself and an initiative that came from that. So the group is the Peri-operative Senior Nurse Working Group in the South Southwest Hospital Group. It's co-chaired by the Chief DON of the group and by Miss Grace Reedy, who is with the Royal College of Surgeons in Ireland. So automatically we have a collaboration there external to the South Southwest Hospital Group, and again that's extremely beneficial as an external source. So who sits on this group is the Assistant Director of Nursing with responsibility for the Perioperative Department. We have a representative from the National Treatment Purchase Fund. We have a representative from the National Clinical Programme of Anaesthetics, and we have guest speakers. And the guest speakers are invited in relation to topics that are highlighted as concerns or needing further exploration within the group. Next slide, please, Erica. Sorry, Erica, just the next slide when you're ready. Oh yeah, thank you. So the initiative that I'm going to share with you is the Theatre Foundation programme, and this was conceptualised by the group in 2014 and actually rolled out in 2015. And at the time in Ireland, there were huge retention and recruitment issues around theatre nurses within the operating department. And the operating department environment was also identified as not being conducive to a learning environment, in that the fast patient turnover and the equipment just did not allow newly qualified staff or staff new to the operating department to learn and to become competent in their practice and in the delivery of safe care. So again, the continuous delivery of safe quality patient care using evidence-based practice was very much to the fore and to the priority of this Theatre Foundation programme, but also looking then at effective management of human resources and succession planning, and looking at management into the future and service delivery into the future in relation to advanced nurse practitioner roles and clinical nurse specialist roles. So moving on, well, then we have our Theatre Foundation programme, and just to share with you the short-term aim, and this was to facilitate the development of safe and effective nursing practice through competency development in the OD. And the long-term aim then was retention and recruitment, and it was developing a perioperative career pathway for programme participants. And again, the programme was to be cost effective. Now, interestingly, what we have seen in relation to the perioperative career pathway, a number of participants who have completed the Theatre Foundation programme have progressed on to do a postgraduate diploma in perioperative nursing and followed on to the master's programme after this. So this was actually our long-term aim, and we have seen this now 5 years down the track. We have seen nursing staff who have completed right up to master's level. Next slide, please, Erica. So just very briefly, it was funded by the South West Hospital Group, a 15-week period incorporating 3 theoretical days, an expectation of clinical competency achievement record, and the clinical competency achievement was under mentor supervision. It was NMBI accredited and involved multidisciplinary healthcare professional teamwork, including nursing, surgeons, anaesthetics, radiographers, health and safety, risk managers. So everybody contributed of their time free of charge, generously, in the best interest of delivering safe, quality patient care in the operating department. Next slide, please, Erica. And just in relation to evaluation of the programme, you will see in the attendance that over 120 people have completed the programme over the 5 years, with the rating of excellent being between 67% and 80%. You can see good and average there as well. And in relation to facilitators, we have had 152 facilitators across the healthcare professions contributing to this programme over the 5 years. So this has to be commended and acknowledged, because these healthcare professionals are giving their time in the best interest, again, of safe, quality patient care. And what is, I suppose, what is really positive about this programme is it is transferable to all specialties if the model is easily adapted. Erica, next slide, please. So the challenges in 2021 from a theatre perspective, and also from a Theatre Foundation programme perspective. So we have seen our programme content obviously will include COVID-19 in the operating department, and particularly around PPE and the specific PPE in relation to aerosol generating procedures, in relation to airflow in the operating theatres. And you saw from my first slide actually the how old part of the building is, and then how new other parts are. Now we have 3 theatres where our turnover time post COVID-19 will be 10 minutes. However, we have 4 theatres in an older building where currently post COVID-19 our turnover time will be 1 hour. So this is very concerning, because again this impacts on our productivity. There is a plan in progress in relation to appropriate airflow being implemented or inserted into these operating theatres, but this will take time. So again, it's then looking at staffing resources within the operating department and how to use these staffing resources as effectively as we can. It's managing theatre staff anxiety also. And again, we'll be looking at virtual delivery of our programme in 2021. Next slide, please, Erica. So the Senior Peri-operative Nurse Working Group has worked exceptionally well. There is a group in the Ceuta Hospital Group, the Dublin Midlands, Ireland East Hospital Group, and the RCSI Hospital Group are currently in the process of setting up a similar group. The University Limerick of Hospital currently does not have a nurse working group. However, coincidentally, this week when I learned I was speaking at this, we had communication from University of Limerick in relation to sharing the Theatre Foundation programme. So it just shows that networking can benefit the safe delivery of quality care. Next slide, please, Erica. So perioperative nursing and COVID-19 and where we're going from now. Nurses are pivotal in the delivery of healthcare, and this has been very much to the forefront during the COVID-19 pandemic. Nurses demonstrated care, commitment and compassion, but also demonstrated huge flexibility and adaptability whilst maintaining the patient at the core of their care at all times. And though I know funding and resources will be under constraints, it is only through supporting education of nurses that we will be able to expand and extend the perioperative nursing roles into clinical nurse specialist level and A&P level, and to grow nurses to meet the service demand following in the COVID-19, I suppose, aftermath. Next slide, please, Erica. I suppose this example is just one of the tangible benefits of a perioperative network, and therefore, you know, when we look at it at having a national group, professionally, I think this would work exceptionally well. It would be a powerful forum for communication, sharing ideas, standardising approaches, shared learning, problem solving, and accessing local innovations. Healthcare professional networks can use the expertise and knowledge to drive timely, efficient change effectively. And most importantly, a national group as well would allow for information and communication to filter down faster to the frontline worker. The information would be delivered in a collaborative, cohesive and timely approach. And I think this is very significant for frontline workers because there are challenges in getting a huge amount of information that can sometimes appear confusing. So a national network that delivers accurate information would certainly be of benefit. Again, however, we must be cognizant of the fact that there are so many groups that people are attending now. But post-COVID-19, a lot of our meetings will be facilitated through virtual platforms. And again, this allows for better attendance. Next slide, please, Erica. And just to leave you with, you know, a bigger picture of a possible European peri-op group that in hindsight, when we look back over the COVID-19, our approach could have been managed very differently had we had that cohesiveness at a European level. And here we have Oscar Wilde. We are all in the gutter of COVID-19, but some of us are looking at the stars. Thank you very much.
Brenda, thank you a million for that perspective, and certainly I'll come back to you later on maybe how we help support you more on the network and the perioperative network there. So very, very interesting development. And so we move on then to our last speaker is Professor Tom O'Connor, and he's the Deputy Head of the RCSI School of Nursing. And Tom is going to give us a perspective from the nursing profession on perioperative care and recovery of services and so on. So Tom, over to you, and thanks again.
Thanks very much, Kieran, President. Thanks for the opportunity to talk to you this evening. So what I'm going to do really is outline some developments that we have in the School of Nursing and Midwifery here in RCSI in relation to perioperative nursing. Some of the program that we're going to talk about this evening was something that was planned before COVID, but I think COVID makes it even more relevant in terms of how things are developing at this time. So as Kieran has said, I'm the Deputy Head of School and the Director of Academic Affairs at the School of Nursing and Midwifery here in RCSI. So we're the largest provider of postgraduate education programs in the country across a range of specialities. So everything from the acute hospital settings, their ICU nursing, CCU nursing, emergency nursing, and perioperative nursing with currently with Beaumont Hospital. But we also provide postgraduate training and education in other areas across community care and non-acute sectors. One of the issues for areas and for postgraduate education in nursing education has been the fact that it has been largely centred and rightly so around teaching hospitals. But one of the difficulties, and just I think Brenda was picking up some of that in the last presentation, is that it doesn't give equality of access to nurses from right across the country from all the different hospitals to programs. So, for example, we see even our own hospital group, as I said, we have for some time run a perioperative nursing program with Beaumont, but not all of the hospitals in the group have access to that program, in that they would have to send their nurses to Beaumont for a period of time to complete that training, because that's where the program organically grew up and was based. Okay, so as in part of our planning as a school in terms of looking at nursing education more generally in this area and in others, I should say, we've been trying to look at a more national perspective about how postgraduate training and education for nurses should look. So in this regard, given that we are here in the Royal College of Surgeons, surgical nursing is a very apt place for us to look in terms of how we're rolling out programs like this. So in this regard, then we've developed a surgical nursing program which we has just been approved and will be delivered to and available to nurses and midwives right around the country. So maybe if we could just have the next slide there, please, Erica. And I'll just talk a little bit about that and what it is. So when we developed this, and it is a suite of programs, there are 3 awards. These are, as Brenda would have referred to in her last presentation, postgraduate diploma, postgraduate certificate, and master's nursing programs in the care of the surgical patient. In looking at this as well, we recognise that there is obviously a need for more training and education for the perioperative environment, because I think we all know of the shortages that are in this sector, both pre-COVID and I think now post-COVID is something we're really going to have to grapple with in terms of shortage of specialist nursing personnel to work in these areas. So that perioperative environment, absolutely, there's a need for that. A need for people to be able to access these programs from outside of the large teaching hospitals, and to be able to train and to work in their own environments while doing this program. But then secondly, and there hasn't been a lot of postgraduate education and training for those who are working in more broadly in surgical care, be that on surgical wards, looking after patients pre and post-operatively in day wards and a range of surgical wards. So we're trying to address that in this program as well. So the program has 2 strands, a perioperative strand and also a pre and post-operative care strand. So the program is delivered, like all of our programs, by blended learning with online and clinical components in it. There's a clinical competency element in it, and we have in this regard, we have employed tutor Sinead Plunkett, who's on the line this evening as well, is looking after this program from the point of view of working with the nurses in developing their clinical competence in this area, and working indeed then with the staff in the theatres in the hospitals in different areas who may not have had access to these programs and may not be aware of the sort of educational development in that regard. So the key thing for this is the students carry out the clinical component of the programs in their own hospitals, where we have a clinical learning agreement to be able to carry this out. So Eric, if you could just flick on to the next slide, please. So just to give you an idea of the model of the program, we model this program in such a way, we model all of our programs in this way to allow for the development of nurses and midwives, and to be able to step on and step off in a range of ways to a program. So you'll see here, in terms of this program, we have a number of core modules to the program, principles of surgical practice, and then 2 strands, as I've mentioned already, one looking at the perioperative side and one looking more at ward-based care. So you see modules there in that regard. So you can take 3 of those modules and get a postgraduate certificate. Then further on to that, to the postgraduate diploma, again, that Brenda would have mentioned in her previous presentation. In that regard, there are core learning, there are anchor modules that we use again across all of our programs in relation to research, leadership, and then that clinical component of the programs. So if you put those 60 ECTSs together, then you get a postgraduate diploma. And then further to that, in another year, in a capstone 30 credit module, you can progress then to do your master's. And all of these modules then can be taken as standalones at any time. So people can come along and take one of these modules if they just have an interest in a particular area. So we've been, as I said, we offer a lot of postgraduate education, and we found that this flexibility of offering is a key thing in terms of nurses being able to engage in education and training, and to be able to, in some senses, step on and step off at various points, but to be able to build their educational abilities over a period of time, right the way up to master's level. So that's the outline of the program as it is. We hope very much that we will be able to engage with hospitals and theatre staff right around the country in terms of the delivery of this program. And indeed, in our initial advertising, we've had a lot of interest in the program. So we're very interested in working on this on a national basis and linking with colleagues, yourselves, and networks all over the country. So that's my little piece, Kieran, on the program as it is.
Tom, thanks a million for that overview. Again, lots and lots of good stuff there around education and training, and we do have to look at how we support all our teams, and lots and lots of new people who've joined our teams. We've never had more interns than ever before, and so on. So look at the whole education offering out there is going to be very important. So again, just to thank all our speakers for all of the great presentations and updates there tonight. And I'm going to get over then to the question and answer session. So we've got a couple of questions coming in on the chat function. Just to remind everybody, use the chat function, get your comments in. And I might just go to one of the ones that came in early on in the talks. And it's probably a pretty straightforward one. And I might just put it to Paul Ridgeway as a clinical director in the hospital. We've been asked basically, should we use the word self-isolation instead of cocooning when we're talking to patients about requiring them to, in the period prior to surgery, and that they may only associate cocooning with the elderly population. So I guess that whole communication and terminology thing that we've latched onto very quickly during COVID-19, some of it actually we may need to not have anymore because it actually could have bad connotations and confusion. So what do you think of that, Paul?
Yeah, Kieran, I think you're right in that a lot of the terminology that we use has to be very carefully thought out, you know, the difference between social and physical distancing and so on. Having said that, the term cocooning has been used quite a lot because patients do know what that is, and self-isolation, while patients may know what that is, often you have to go on and explain in great detail really what that is with regards to exactly what's involved with them at home and so on and so forth. We do have concerns around the compliance rate of a 14-day self-isolation pre-operatively, in how well people will be actually able to manage to do that, particularly since the 18th of this month. And I wonder whether over time we will be more pragmatic around thinking maybe 7 days may be enough. And the reason for that is the vast majority of patients who come in contact with COVID, as we know, will start to display symptoms or at least be positive 7 days. And that, in concert with the screenings, all being the screening is by no means perfect, with about a 73% sensitivity rate of FlowFlex and as low as 63% sensitivity rate of the quicker Gene Expert test. So from those perspectives, I think you're right, semantics is important and the nomenclature that we use. But I suppose for us, what we found is using the word cocooning is actually a good way of conveying what we mean. But you're right, self-isolation is probably more appropriate.
Yeah, well, again, I think it's up for debate, isn't it, on that? And I know you've been heavily involved in producing the consent guidelines during COVID, and they're, again, available on the web, and we put a link out tonight. But so it's a very important area. Does anybody else want to comment on that? Or because I have another big question here from the panel.
Kieran, if I can come in, it's Ronan O'Connell here. Just and both you and Deborah will be aware of my concern of using the term guidelines. And Paul, your very good presentation, you repeatedly referred to guidelines, and yet within your patient pathway, you seem, as you've just explained, to recommend, shall we say, 7 days of self-isolation as opposed to 14. And I'm sure I'm not one to disagree with you. And yet, if you come off the plane from somewhere else, you're supposed to self-isolate for 14 days. So guidance is much better term, I think, than guidelines or recommendations. If you put the term guidelines, then it has a medical legal connotation that may actually come back to bite us. So I would just say use the term recommendation or guidance rather than guideline.
Okay, thank you, Ronan. That's great, and important points there. I think back to the panel, an interesting question came in, and this is a biggie, so I guess we're going to have to think about maybe a number of people want to come on this. The question is basically, as we return to elective surgery, how are we going to manage the growing public waiting lists in kind of combination with the private waiting list, so that there's sort of some equity of access? And it's a challenge. And I know, Paul, you mentioned there about let's just say the caution we need to be about outsourcing, holding on to your teams, the resourcing side of things. So maybe Debbie, as a national lead, you're obviously looking at this very closely with the HSE, trying to look at the waiting list, look at the priorities, looking at kind of, I suppose, the fairness that will come into these waiting lists, because everything's a little bit chaotic at the moment. So you're on mute there, Debbie.
Thank you. It's an extremely challenging area. I think there's no doubt that we need to maintain services to the maximum extent possible in our major hospitals, in all of our Model 3 and Model 4 hospitals, because there are some patients whose needs can only be met there, whether they're public or private. There are a proportion of patients whose needs could be met in the Section 38 hospitals that are currently available to the HSE, but making those pathways work can be quite challenging. And as activity increases, we need to be very careful to make sure that the standards of care available to patients and the precautions available to patients are the same across both sectors. Obviously, it's been slightly challenging to plan at the current time, because we don't yet have a political decision on the future state of the health service in the coming months. It does take time to get pathways up and running. It seems that some of the private hospitals are beginning to develop pathways for a proportion of patients. But I think we shouldn't let the conversation only be about what happens to private hospitals. All of our hospitals have to be delivering surgical services. We must maintain our hospitals in the public sector, and we must maintain the capacity to deliver surgery of all sorts in those hospitals. I think of hospitals like the South Infirmary, and I mean, they deliver an amazing elective service to the people of Cork, and that's a huge, huge resource. And we can't allow that to go off the radar because there's availability of some private capacity at the moment. I think we have to make sure that our Model 2 and Model 3 hospitals are up and running in as safe a way as possible, collect the data, demonstrate that we're delivering safe care to these patients, and get those hospitals working efficiently. And sure, if there's capacity in private hospitals, we should be using it. The NTPF model has traditionally worked quite well for doing that. I guess my personal opinion would be that would be a superior model of engaging with the private sector, but obviously that's not a HSE policy matter. That's just a personal opinion. Thank you.
Thank you very much, Debbie, but a very well-informed opinion in that. And Paul, actually, you mentioned in your discussion there that as the elective work kind of fell off a cliff, I guess, to a certain extent, the acute emergency care actually became much more efficient, and for obvious reasons, beds were available. There was a lot of things like that. But before, and as things return, we've got to be careful that we don't lose maybe some of the learnings here. It's clear that actually having separation between scheduled care and unscheduled care, and has been designated units that perhaps deal with scheduled care. We see the turnaround that the colleagues in Cork and the South Infirmary there have, and how busy they can be when they're a dedicated elective unit. So are there things we need to learn that, from this, and actually maybe not go back to doing, and what would they be, Paul?
So I think that's a key point, Karen, and as you say, that the separation of elective and acute services brings efficiencies to both, and as Debbie was saying, that the model in which that will be put in place is a matter for the system to sort of tell us, but us to hopefully have an opinion within that. Specifically around acute care services, surgeons in general don't like not being busy, and when they were given an opportunity to look after the acute care patient, a care patient which was fit in to an elective on most sites, and there are a few notable exceptions to that they really excelled, and they built bigger, better, stronger ASAUs, which are the acute surgical assessment units, both the accredited ones and non-accredited ones. And we were delighted in the program to receive more interest in ASAU productions across the various sites. Now, having said that, we still have 26 EDs, which on average have about 5 to 6 admissions for acute general surgery a night. And the question for the country, and it's a fiscal question as much as anything else, is can we sustain that? And like Debbie was saying, can we stream our elective patients more effectively in the public sector hospitals by their need? If they have complex needs, to probably the larger Model 3, the Model 4s. If they have less complex needs, then perhaps towards some of the Model 3s and Model 2s. And that would be the perfect handshake, if you like, between elective and acute care while keeping both streams protected.
Yeah, thanks, Paul. I mean, that's great. And one of the things that I also noticed in your presentation there, you had your categories of patients, and because at the moment I think there's a certain perception that all patients coming for surgery must cocoon, I'll use that word now, for 14 days and then get a swab in a pre-op assessment before their surgery. That seems to be a blanket rule, yet you've approached this in a much more nuanced and maybe risk stratified way in Tala. How did you come up with that sort of protocol?
So what we did was we had a long engagement with our infection control committee, and over the last number of weeks, and I mentioned it at the end with regard to decision making, we were very flexible, but also we have very good feedback tools in place. So we have been screening all our patients in the acute stream for a number of weeks now. So we have a good information around the community prevalence of asymptomatic patients, which is, if you like, the key here. The tools that we have are still not perfect, but we do need to be pragmatic with knowledge of our local population regarding how compliant they would be with a full 14 days. And that's why in conversation with our infection control committee, we say at least 7 days. Now, the ideal situation is still what we recommend, but it's not always achievable. So our guidance says at least 7 days. And that, when the numbers are small, is actually not a huge resource. We have the teams ringing the patients to ensure that they're adequately self-isolating or cocooning, whichever terminology you want to use, with the appropriate guidance. The problem is when we scale that up, when we see more and more day case surgeries, when we see more and more endoscopies. Now, we have had a fair elective stream in endoscopy still going. They've been all the time sensitive endoscopies, high-end endoscopies. They still have been going, but they have been screened, but not with swabs. Simply, we just didn't have the capability to offer that to every single patient attending for any procedure. So we've had to risk stratify then in that way. And I think that's the biggest challenge that we will have, is how do we administer that pre-assessment, which is now going to be enhanced and including swabs. So simply, where is it going to be done? When is it going to be done? How is it going to be followed up? And most of our services across the country have a small amount of resource applied to the pre-assessment, and that simply needs to be ramped up.
Thank you, Paul. Brenda, I mean, there's an obvious one, I suppose, those sort of protocols, learning, sharing information. One of the real reasons why a perioperative network like you described nationally would be hugely useful. If you know, what would you need and what would the network need to create that national perioperative network, which could be so valuable as a way of getting communication, training, harmonizing standards and so on? What do you think you would need to sort of establish that right now? And could the college, for example, help you with that?
I suppose, first of all, we know that there are nursing perioperative groups within the actual hospital groups, bar the University or bar Limerick. So we already have within the groups a network structure. I think what we would need is a expertise from I suppose the perioperative multidisciplinary teams. It's good, you know, now we have nursing, but a perioperative network should incorporate all healthcare professionals involved in the perioperative pathway. So again, you know, it would be important that the group wouldn't be too big, but again, you would need a representative from across the multidisciplinary team, and again, the Zoom or using a virtual platform is excellent because you do not have any travelling issues or have anything like that. You know, you don't have any issues and you're going to have better attendance, and the meeting would then be beneficial. I suppose what we have seen from COVID-19 is that we, you know, organisationally we try to manage, but this needed a unified emergency response nationally. And again, that's where our national network from a perioperative perspective would fit in. So we need effective team members who are, prioritising the agenda that's critical to the service demand at the time, and who are willing to share their information and knowledge, and to identify the problems that are currently within the health service from a perioperative perspective. I mean, we are facing huge challenges. Our waiting lists have grown dramatically over the past number of weeks. Again, we have our social distancing, we have our capacity in the hospitals are reduced as a result of this. So again, that's going to impact on the turnover of patients within all of the hospitals across the country. So it would be very beneficial as a group to sit down and try and manage and problem solve and see how we can best facilitate continuing on patient turnover and meeting the service users' demands, both in an elective and in an emergency capacity. I hope that answers your question, Kieran.
Yeah, no, it does, Brenda. Thanks very much. And Tom, do you want to comment on the similar vein there, and how some of the work you guys have been doing in school, and and the whole new role that people, advanced nurse practitioners, and the different ways we might actually come at the resourcing, because we're going to have significant challenges, I think, resourcing care in the kind of less efficient world we're going to find ourselves in very soon. You're on mute there, Tom.
Sorry, thanks, Kieran.
Yep.
Yes, the whole idea of networking and bringing people together is very important. And I think, as our organisation like ourselves, for example, where we have a lot of people coming to us from different parts of the country, and B, we have this multidisciplinary setup already, it makes sense that that we try and bring people together from all disciplines, from nursing and from surgery and from all over the place together, to try and work together, because it is, I mean, if I just look within our own profession in nursing, it's multi-layered in terms of the developments that need to take place in perioperative care, for example, all the way from from education, but also in terms of bringing evidence to what we're doing, and all of those sorts of things. So as a college, I mean, I think we can play a strong part in that, in terms of facilitating that type of networking experience for nurses and for the wider healthcare disciplines.
Great, thanks, Tom. So look, I'm conscious of time, and as I mentioned at the start of the webinar, this is the last webinar that our president, Mr. Ken Mealy, will be attending as president, because he demits office next week. And I guess it's just, I was talking to him earlier on today, and it was just asking, would he maybe give a reflection on, say, his term as president, and sort of how he looks forward to see how Irish surgery will, as always, prevail during these crises, but yet come out a lot stronger and better. When I look back myself, it was an absolute pleasure to work with Ken and to support him in surgical affairs as the president. There were many highlights and so on, but I guess the most enjoyable couple of days we had was when we were all over in Uganda together at the COSEXA examinations and programs there, and we had some good times, great networking and so on. But I suppose throughout the whole couple of years, Ken, I mean, your leadership has been extraordinary. I think you resonate very easily with everybody in practice, our trainees, our members, our fellows. All of the agencies like the HSE, the department, the medical council, all those stakeholders representing us internationally, flying the flag for the college and Irish surgery and Irish medical education as well, so on, has been phenomenal. And you've shown massive energy, massive leadership, and it's been an absolute pleasure to have you on this. And so I look forward to your few minutes of reflection here on the few years gone past. So thank you.
I don't know how I'd follow on from that, Kieran, and how I do it in a few minutes is another matter, but I would like to take this opportunity to thank you and Padraig, Erica, Paula, Adina, and all the other team members that you have in surgical affairs. I think you've done a fantastic job, particularly during this COVID pandemic period, in terms of bringing together a huge amount of documentation onto the website, collated from our own specialty groups, our clinical programs, from the other colleges, from working with the Forum of Postgraduate Training Bodies, our sister colleges in the UK, the College of Anesthesiology. And I think you've done that with aplomb. You've brought in new technology. You've introduced new ways of learning, and I think that's commendable. You've really risen to the challenge. I said tonight I'd give a plug for when we talk about new ways of learning. I said I'd give a plug to Peter Gillen, Winnie Ryan, Donncha Ryan, and Conor Dunphy, who've produced another video educational piece on video consultations, and that I think will be going out on the website next week. And I think that's just, if we look at what's happened with the COVID pandemic, it's really upended surgery. But I think it would be an awful shame if we don't take some of the good things that have come from that. And that is new ways of learning, for instance. We can engage with our fellows and members, and ironically, my sense is we engage with our fellows and members better now than we did 3 months ago, 6 months ago, or a year or two ago. And that's because we have embraced this new technology. And I'd love to see that being continued in various educational guises. I think another benefit from the COVID pandemic, if I can use that phrase, is that I do think there is a greater understanding in the health service that we can't go back to the old ways of working. We cannot have clinics with 40 or 50 people. We cannot have trolleys in corridors. We cannot have 100% occupancy in our hospital beds. If ever it was an argument for separating the scheduled from the unscheduled surgical streams, this is it. And I think we will have a strong voice now at the HSE arguing for these changes, particularly through our clinical programs. And I really have to commend our clinical leads and clinical advisors. Debbie is there tonight, John Hyland, David Moore and Paddy Kenny, and the clinical advisors in all the specialties now. Paul Ridgeway, you heard tonight. So another benefit from all of this, I think, is greater engagement with the health service. I think many of our clinicians have stepped up, have shown that leadership that you talk about, Karen, and I think that's been really beneficial. So while the COVID pandemic has, as I say, upended what we've done, has upended our whole approach to surgical services, never did any of us consider how bad things were 2 years ago, that they could even get to the stage that they are now. But here we are, and I think many of us have stepped up to the plate. We will have new ways of working, and despite the problems, I'm actually enthused for the future, because I see many clinical leaders, not just in surgery, but in our nursing colleagues, in our anaesthetic colleagues. I see a new enthusiasm for working together in ways that we have never done before, and I think this will continue. So I'd finally like to end by just acknowledging our fellows and members. All of you have been incredibly gracious and generous to me and to my office. I appreciate that very much. Hopefully I've represented you appropriately in the different fora where we do interact with other healthcare providers and educators. It has been a true pleasure on my behalf to represent the college, and I look forward to supporting the college, our fellows and members, in whatever way I can in the years to come. So thank you very much for that opportunity to speak, Karen, and thank you and all your colleagues in Surgical Affairs.
So thank you, Ken. So there's no more to be said. I'm going to ask everybody to unmute themselves, turn on your cameras, and give a virtual round of applause to the President and wish him all the best. Thank you all tonight.
Thanks a lot, everyone. It's been my pleasure, and I mean that sincerely.
Well done, everybody. Thank you very much, and good night, everybody, and we'll see you again next week. Thanks again. Bye.
Bye.